patients in whom antiarrhythmic drugs have been ineffective or have caused side effects, an alternative option is to perform an ablation to help them with their symptoms. In patients with atrial fibrillation, we know that the majority of the AFib is caused by abnormal electrical firing that comes from these structures in the left atrium called the pulmonary veins. The main goal of atrial fibrillation ablation, called pulmonary vein isolation, is to cauterize entirely around the pulmonary veins so that good scar tissue can form around them. This way, when those veins start to fire, the electrical signal doesn't reach the rest of the atrium, thus keeping the patient in rhythm. You will come to the hospital, and in the EP lab, you'll be put to sleep with general anesthesia so that you aren't awake for any of the procedure. Once asleep, one of our partners will perform a transesophageal echo, or TEE, where an ultrasound camera is passed down your throat to look at the heart and make sure there isn't any blood clot already there before we start. Once we get the green light to proceed, we will put several IVs in both groins and occasionally the neck. Via these IVs, we place several catheters up in the heart. We pass catheters across to the left side of the heart and cauterize around the pulmonary veins. You typically spend one night in the hospital, and if all goes well, you are discharged home the following morning. You will need to remain on blood thinners after the procedure. The success rate for this type of ablation varies from patient to patient based on several factors. One factor is the type of AFib you have. For example, success rates are higher with paroxysmal AFib, the type of AFib that comes and goes on its own, as opposed to persistent AFib, the type that usually needs to be shocked back into rhythm. The other important factors that affect the success rates of ablation are the other medical conditions you have, including heart failure, obesity, lung disease, etc., etc. We will discuss these with you in person. The main complications of an AFib ablation include, but are not limited to, the following: narrowing of those veins, damage to the phrenic nerve, that is the nerve to your diaphragm or breathing muscle, need for a permanent pacemaker, among others. However, the four things we focus most on are bruising or bleeding near the IV sites. We use ultrasound to guide placement of our IVs in the groin, and this has significantly decreased the rate of this. Second is bleeding around the heart. If this happens, we would need to drain it emergently, and in rare cases, it can require surgery. The third is stroke. If a blood clot was to form in the heart during ablation, that could leave the heart and cause a stroke. Thus, we do several things to help decrease this risk. First, we have you take blood thinners before and after the procedure. Second, we perform the above-mentioned TEE to make sure there are no clots before we begin. And lastly, once our catheters are in place, we give additional IV blood thinners to keep the blood thin during the case. The fourth complication that we really worry about is a very serious but fortunately rare complication called an atrial esophageal fistula. This is a hole between the back of the heart, where we ablate, and the esophagus or food pipe. If we look under X-ray, unfortunately we can't see the food pipe. Thus, we wouldn't be able to see if we were burning right on top of it. To help guide us with this, after you are asleep, we place a wire down your throat that allows us two things. First, it allows us to see under X-ray where the esophagus is. Second, it tells us within 1/10 of a degree what the temperature is in the esophagus. Therefore, when we see the temperature rising, we can use that to guide us away from burning in those areas. We will discuss the specific complications and their rates with you in person.